A case of intractable heart failure in a 24-year-old young man who presented with shortness of breath. So he immigrated from Mexico at a young age. At age 11, had pretty significant symptoms. They found a congenital LVOT obstruction, and he underwent subaortic membrane resection. At age 15, he had Konno repair, which involves ventriculotomy, aortotomy, and a bioprosthetic aortic valve, and then a patch repair, a pericardial patch repair. He presents again 8 years later with severe bioprosthetic aortic stenosis, has a 31 millimeter St. Jude bileaflet prosthesis placed. Then he comes to our institution for the first time 9 months later with signs and symptoms of heart failure. He also notes 2 months of progressive dyspnea and decreased exercise tolerance. He was previously, after his surgery, fairly unlimited. On physical exam, you'll notice the wide pulse pressure with the blood pressure of 140/38. His heart rate was around 100. He was breathing quickly, but satting normally. His physical exam revealed a mechanical S2, as you'd expect, a harsh 3 out of 6 to and fro murmur across the precordium, an elevated JVP, hepatomegaly with a palpable liver edge, and 3+ lower extremity edema. His early clinical course in the hospitalization included medical management with IV diuretics and afterload reduction, but this didn't work so well. He had worsening liver function, lower extremity edema, and ascites. Further diuresis was subsequently hindered by hypotension and acute kidney injury, in addition to a rising lactate. Subsequently, we initiated inotropes, but again, with only minimal improvement. At this point, we really had to figure out why this young gentleman was having this pretty significant presentation of heart failure. This is his transthoracic echocardiogram presentation, which revealed a well-functioning aortic valve prosthesis, mild LV dysfunction, and an enlarged RV. However, if you look closely, there was some suggestion of abnormal color flow here. This is a short axis view. Based on that, we proceeded to Transesophageal Echocardiogram, which again revealed a well-functioning bioprosthetic, or rather mechanical aortic valve. But when color flow was added, we saw this abnormal flow from the ascending aorta into the right ventricular outflow tract. Here's some additional views of that. There also appears to be discontinuity in the wall there. We subsequently proceeded with cross-sectional imaging using CT angiography, which confirmed our suspicion that there was an ascending aorta to right ventricular outflow tract fistula. In the setting of this fistula, we did a diagnostic catheterization, which revealed markedly elevated right atrial, right ventricular, PA, and wedge pressures. Additionally, you'll notice the pretty significant step up in oxygenation between the RA and RV, confirming the shunt, left to right shunt. Angiography revealed free flow of contrast from the ascending aorta to the RVOT, and we were able to cross through with a straight wire and a Benson wire and the pigtail. So now we have a young man with right heart failure due to an ascending aorta to RVOT fistula. At this point, we had a multidisciplinary conference with our surgical colleagues, with congenital cardiologists, and came to the conclusion that in the setting of his 3 prior sternotomies, if it was at all possible, we should attempt a percutaneous solution for this fistula. Thus, with an Amplat superstiff wire, we were able to cross the lesion. We did coronary angiography to confirm that we would not be interacting with any of his coronary arteries, and he, of course, had no significant coronary disease. Using a Ty-Shack balloon, we sized the lesion. We had some idea of the size from the CT angiogram as well. It was around 1.7 centimeters in diameter, or rather millimeters in diameter. So then we needed to decide which device we would use to close it. We considered a ductal occluder, but the largest size here, 1210, would have been too small for this lesion. Thus, we took a look at our vascular plugs and decided that the AVP2 would be the appropriate size, a 20 millimeter AVP2, which is 16 millimeters in length. We thought that it would sit nicely in the defect, have stability in this highly mobile region, and do as little as possible to disrupt the aortic outflow and the right ventricular outflow tract. Here's the device in position, still connected to the cable. You can see by angiography that there is no longer significant flow across the fistula. You'll see that there. We subsequently left the device in place for about 10 minutes to make sure that we fully imaged it, realizing that it has the potential to interact with that mechanical valve and to obstruct flow out of the right ventricular outflow tract. We did significant transesophageal echocardiography to make sure that that was not the case. And you can see here that there's really minimal color flow across the fistula. Satisfied that it was in a reasonably safe and stable position, we then deployed the device in the fistula, and you can see its position there. Again, we remained for about 15 minutes looking at the device very carefully to make sure that it did not move and it did not disrupt any associated structures. You can see the 3D TEE on the right and the color images on the left. No significant flow across the device. It's well seated, it's stable, and it remains stable. I'll remind you of the hemodynamics before the fistula was closed. After we closed it, we saw a significant reduction in his RV and PA pressures, and importantly, a significant reduction in the shunt fraction. He was weaned off of inotropic support quickly. He subsequently had brisk diuresis and improvement in his organ function. He symptomatically improved as well as walking around the hospital 2 days later, and he was discharged home in stable condition 4 days later. He followed up 2 weeks and then 3 months later in stable condition with improved exercise tolerance and no evidence on echo of aortic or pulmonic stenosis or any disruption of the outflow tracts. Additionally, on 3D CT imaging, the device was in stable position, had not moved. So aortic RVOT fistulae are quite rare. They can occur in the setting of endocarditis, in the setting of patch repair, in the setting of surgical aortic valve replacement, and there's a case report of it happening in the setting of a TAVR as well. In our case, it likely resulted from partial dehiscence of the previous pericardial patch that was used in the original Konno repair. And in the setting of the severe bioprosthetic aortic stenosis, which, as you know, would result in a high-velocity, low-pressure flow in the immediate post-stenotic area, this may have been masked. Looking back at his old surgical reports, there was a brief mention of a potential fistula there, but it was not closed because it was thought at that time to be hemodynamically insignificant. In the setting of the relief of this obstruction, when he got a new aortic valve and had higher flow across the aorta, the pressure likely increased. There was an increase in the ascending aorta to RVOT gradient, and thus this allowed increased shunting. In that setting, the fistula became clinically manifest and had a greater impact on the RV. Echocardiography, cross-sectional imaging, and catheterization really allowed us to fully understand this defect, and in this case, a transcatheter approach was feasible, safe, and effective in terms of reducing his symptoms and getting him out of the hospital. And considering his significant perioperative risk, we feel was the appropriate approach. With that in mind, if there's any questions, I'm happy to take them.
Yeah, I got a question. So can you describe this defect a little better for us? I think you told us the size, the diameter of the defect. Did it have some length to it? You chose a device that's more of a vascular plug?
Yeah, it was not fully circular, it was ovoid, but it was on CT 1.8 by 1.6. And when we took the Taishak balloon, we got numbers that were very similar. And because the concern was that this was dehiscence of the previous pericardial patch repair, we felt that this circular device would fit quite well without disrupting anything else.
And do you think that your device, your AVP2, protruded either in or out of the two structures there? Did you think about doing more of a pancake type of thing with an ASO?
We thought about it, but once it relates to two things. One is operator expertise, I guess, and the second is that we felt that the lesion was long enough that it wouldn't disrupt the structures, and thankfully it didn't.
Yeah. Good.
Any other questions?
Thank you.
Thank you.